Hi, my name is Antonis Pavlidis. I'm a consultant interventional cardiologist and lead of the CTO service at St Thomas's Hospital in London. I'm going to present the case of a 50-year-old male with diabetes, hypertension and hypercholesterolemia who sustained a non-STEM in 2015. At that point, he refused to undergo an angiogram. He was therefore managed medically. He presented a few years later in clinic with typical exertional angina. He underwent a cardiac MRI scan which showed normal LV function and viability in all three coronary segments. His coronary angiogram demonstrated severe three-vessel calcific disease. The patient was offered coronary artery bypass grafting, but he declined. After discussion at the MDT meeting, he was referred for complex multivessel coronary angioplasty. This is his coronary angiogram demonstrating a long segment of severe and calcific disease of his LAD. The LAD was wired with a cyan blue wire and a 135 cm corsair. The cyan blue wire was exchanged at the distal vessel for a rotafloppy wire. We subsequently performed rotational atherectomy with 1.5 and 1.75 mm burrs. Significant dissection of the mid-vessel occurred following rotational atherectomy. We attempted balloon dilatation with a 2.5 mm non-compliant balloon, which failed to dilate the lesion. Subsequent attempts with a 3.0 mm non-compliant balloon and a 3.0 mm cutting balloon with the assistance of a 6-French guideliner also failed. We then proceeded with a 3.5 mm non-compliant balloon, which once more failed to dilate the lesion. A 3.0 by 12 mm OPN balloon was delivered to the mid-vessel and dilated at 35 atmospheres. Although this was initially unsuccessful, when we dilated the balloon further at 40 atmospheres, this managed to dilate the lesion. We subsequently delivered several drug-eluting stents with the assistance of a guideliner, and following post-dilatation we achieved an excellent final angiographic result. The patient returned to the cath lab 3 months later for stage angioplasty to his distal RCA. As you can appreciate, the second diagonal is now occluded and it feels retrogradely via an epicardial collateral arising from the posterolateral branch. The LAD result remained excellent, and the circumflex lesion was assessed with a pressure wire and deemed to be non-flow limiting. It was therefore treated medically. The patient was seen in clinic 3 months following his stage procedure and remained well with no symptoms. This case demonstrates that the use of rotational atherectomy in debulking heavily calcified lesions can often be inadequate. OPN balloons seem to be an effective and safe tool for optimal lesion preparation, either alone or in adjunct with other debulking modalities.